All right, good evening, everyone, and welcome to the Alaska Eating Disorders Echo. This Echo is jointly provided by the Alaska Eating Disorders Alliance and the UAA Center for Human Development, Project Echo. Funding for the Eating Disorders Project Echo has been provided by the Alaska Community Foundation, State of Alaska, and the Alaska Mental Health Trust Authority. My name is Erin, my pronouns are they, them, and I'm an ECHO coordinator with the Center for Human Development's Project ECHO. Our bi-weekly sessions offer a forum for Alaskan interdisciplinary healthcare professionals to connect with eating disorders experts. This is the 5th of 6 sessions running from September through November, and each of our sessions includes a didactic presentation from a subject matter expert, followed by a Q&A and a case presentation, which will provide an opportunity to engage critically and collaboratively with illustrative examples of important and noteworthy topics related to eating disorders and their treatment. Our series has been approved for continuing education credits, and participants can claim 1.5 credit hours per session of this ECHO series. And in order to claim these credits, we ask that you attend the live session, at least 90% of the full session time, and that you complete an evaluation form, after which you'll be redirected to receive and download confirmation of your continuing education credits. Towards the end of our session today, a link to that evaluation will be provided in the chat box, so please keep an eye out for it. I also encourage other participants who might not be seeking out continuing education credits to fill out that survey, as it does tell us how we're doing and how we might improve. All right, a few reminders before we jump in. If your internet does not support audio, in the chat box, there's a phone number to call along with the meeting ID. Closed captions are automatically generated and available by enabling the CC button at the bottom of your Zoom screen. We do invite you to take a moment to turn on your camera if you're available to do so. It's a nice opportunity for us to get to know each other a little bit better. And you can do this by selecting the camera icon on the lower left of your screen. We do ask that you keep your microphone muted during our presentations and when not speaking. You can mute and unmute yourself by selecting the microphone icon on the lower left of the Zoom screen, or by pressing *6 if you're dialing in via phone. And whether or not you've joined in echoes before, it's important to know that engagement with the group is integral to the all teach, all learn philosophy, which underpins our program. And we encourage everyone to ask questions and make comments during the session by utilizing the chat box, or when appropriate, by unmuting yourself and sharing directly with the group. We do ask that you try to utilize the hand raise function in Zoom, as it's a nice way for us to identify speakers. You're also welcome, of course, to private message myself, the session host, or any of our hub team members if you'd like your questions shared anonymously. To help build connections and foster participation throughout the ECHO, we like to start each session with introductions. And in the interest of time, we'll go ahead and do those introductions via the chat box. I see many of you have already introduced yourselves, so thank you for that. If you haven't already, please go ahead and share your name, role, organization, where you're joining us from, and perhaps also a little bit of what you'd like to get out of this ECHO today. Please note also that the opinions of our hub team and presenters are their own and do not necessarily represent those of AKITA, UAA, or any ECHO sponsors. Additionally, Project ECHO is not HIPAA compliant. Therefore, we ask that no protected health information is shared or displayed at any time. And thank you to everyone for following those guidelines. Finally, I want to take a brief moment to pause for a land acknowledgement. Our ECHO team is joining you from Anchorage, and as such, we want to thank the Dena'ina people for their stewardship of the lands, water, air, and all life that sustains us within their traditional lands of the Takatnu Cook Inlet region. We respect the Dena'ina cultural ways and their homelands and shall strive to be good neighbors. All right, so now we'll go ahead and turn our session over to Jenny from the AKITA team to share a little bit about the vision that's driving this initiative, the purpose of our ECHO, what's on today's agenda, as well as to offer some reminders for best practices when engaging in today's discussion. All right, Jenny, over to you.
Thank you, Erin. So glad to see you all here today. I'm Jenny Loudon. I'm one of the co-founders of the Alaska Eating Disorders Alliance, And I'm really thrilled that you're all here with us tonight. We really are excited to have these opportunities to grow our knowledge so that we can better serve Alaskans impacted by eating disorders. Really, that is the goal of this Project ECHO, that together we can grow in our capacity within our local healthcare system so that we can better understand and diagnose and treat eating disorders here in Alaska. But we're also thrilled. I know we've got folks here from South Korea, we've got folks from all over, and it is great to have you all join us as well. Today, during our time together, we'll be learning from the elements of the formal ECHO as well as from the ways that we interact with each other. And so we know that words matter, that they're powerful, especially within the space of eating disorders. And so we will just encourage you, this is an open space where all voices and all bodies are welcome. And we really encourage you to be mindful of the ways that you use words. We do seek to use inclusive and non-stigmatizing language. So let's start with a brief outline of what we're going to be doing today. First, we will have a presentation by Dr. Crystal Cuellar, and it will be titled The Medical Management of Eating Disorders. Dr. Cuellar was born and raised in San Antonio, Texas. She then completed her undergraduate and medical studies at Brown University in Providence, Rhode Island. She went on to complete a pediatric residency at Baylor College of Medicine in San Antonio and a fellowship in adolescent medicine at the University of Washington. So currently that is where she's at. She's now an assistant professor at UW and Seattle Children's Hospital. Her clinical focus is on eating disorders, gender affirming care, and reproductive health. In the outpatient setting, she has provided initial eating disorder consultations, hospital transition support, and ongoing medical care for patients with eating disorders. In addition, she works as an inpatient consult provider for adolescent patients with eating disorders and other adolescent medical concerns. Dr. Cuellar has a passion for teaching and always enjoys community outreach education in various formats. So we're really glad to have Dr. Cuellar here with us today as part of our hub team. After that presentation, we'll have time for some brief Q&A. So if you do have questions, please keep note of them. We'll have opportunities both in the chat or potentially if you want to use the raise hand function. So keep a hold of those and we'll have time to answer some questions. After that, we will have a case presentation by Kim Payne, who is a counselor based in Albuquerque, New Mexico. So with that, I want to give the platform over to Dr. Cuellar to share our didactic presentation.
Thank you, Jenny. I'm going to pull up my slides here. All right, can you see that okay? All right, perfect. So, like Jenny said, I'm Crystal. I use she, her pronouns, one of the adolescent medicine providers in Seattle. Today, we'll be talking about the medical management of eating disorders. So, to start, I don't have any disclosures to make, really, no conflicts of interest. There are a few acknowledgments that I want to make today. So I will be focusing on some of the restrictive eating disorders, mostly anorexia and bulimia. So also just want to acknowledge that there are several other eating disorders, like binge eating disorder and ARFID that I won't touch on quite as much. Some of the concepts will still apply, but happy to bring that back in a future ECHO series in the future. I also want to acknowledge that I primarily work with adolescents, so forgive me if I refer to patients as kids or teens or youth. This is just a general introduction of what we'll talk about here, but let's just jump right in. We're going to start by talking about the Minnesota Starvation Project. It's not my favorite study because it's not very diverse, it's questionably ethical. But I do think it is interesting in terms of the topic of today's presentation. So to give a little background, this was a study done during World War II. It consisted of 36 conscientious objectors of the war who volunteered here. They went through a 12-week control period and then 24 weeks of starvation where they had much less intake than they were taking during the control time period, and then also had increased activity levels, and then went through 12 weeks of nutritional rehabilitation, and that differed among a few of the groups. The most interesting part of this study is what we learned behaviorally in terms of starvation. So the participants were really focused on food and eating and food content. So most of their conversations were around food and eating. Their reading was related to food and eating. They were even daydreaming and dreaming about eating. Other aspects that were pretty interesting were some of the behaviors. So when they did have access to food, many of them were food hoarding, excessive gum chewing, using tons of spice, and then even cutting up their food into tiny, tiny pieces and eating it very, very slowly over the course of hours sometimes. So pretty interesting in that these are behaviors that we see in some of our restrictive eating patients. So told us some good information about behaviors, but also gave us an idea about what we face medically for patients who are in starvation. So taught us a lot about what body systems are affected, how they're affected, and really how they're affected in the refeeding process. So an interesting study to think about, but also acknowledge some of its downfalls. I want to talk about what the importance of this topic is. So if you've been to any of these ECHO sessions so far or interact with eating disorder patients, you know that eating disorders are really serious and complex illnesses from the mental health side, nutritionally, and medically. And the medical complications can be severe and life-threatening. We know that eating disorders, and specifically anorexia in this case, have the second highest mortality rate of any mental health issues, second only to opioid use disorder. And medical complications account for about half of the mortality in eating disorders. So there is other mental health implications in mortality and then other non-related eating disorder deaths, but half of them are related to some of the medical complications we're going to talk about today. Early identification and intervention are really key here, not only for the mental health side of eating disorders, but also in ensuring positive outcomes in terms of medical complications. So we know that if we intervene early, we have less body systems affected and less long-term health outcomes. In one of our planning meetings, somebody said this quote, and I thought it was really important and relevant here, in that eating disorders either get treated or they get worse, but they don't get better. And in medicine, there are a lot of cases where it is appropriate to watch and wait or allow a disease process to present itself. But in eating disorders, doing nothing is really not a neutral event, and we really need to be cautious about taking things slow and really focus on intervening quickly, and whether that means referring to the correct people or addressing some of the medical concerns we're going to talk about today. I'll give a couple of thoughts about what people in the community can do here at the end too. So some general principles here. Anyone can be affected by an eating disorder. So any background, any size, any gender identity, any socioeconomic status. Historically, eating disorders have kind of been attributed with a certain stereotype, but we know how important it is to consider the diversity of eating disorder patients. So I just wanted to make sure to point that out. In that diversity, any patient can be affected by the medical complications we're talking about too. So we need to have a high index of suspicion for all of our eating disorder patients and not only certain subsets. And health complications may not be obvious. Our patients might be acting normally as they were before the eating disorder started or before there was weight loss. We can see them happy, we can see them functioning, they might be excelling in academics or sports or their job or socially. And it might not be obvious that their bodies are actually very sick. So definitely need to continue to be mindful about that too. What we know is that the more weight loss there is and the longer that it happens, the more complications we see and the more organ systems that are affected. So this just kind of ties back into being really vigilant about early identification and intervention. So when it comes to what we look at medically, it really comes down to energy balance. So the energy intake from nutrition and then energy expenditure through activities of daily living, physical activities, puberty for some patients, and even just the energy that's needed to maintain normal body function. When everything is balanced, we have good energy in that's matching our energy out, we get in the stage of growth, especially for young people. Energy storage, where our body is putting away glucose into glycogen stores so that if we do have an energy expenditure, we have something available there that we can use. And all of our systems, our body systems are functioning normally. They have enough energy to sustain whatever their function is meant to be. In eating disorders and starvation, we get a complete imbalance of this energy here. So our energy intake is not matching our energy expenditure. And then we move into functions of breaking down any energy stores that are available so that we can maintain some function with the body. We move to conserving energy by shutting off certain body systems that aren't vital, to really routing as much energy as possible, to pumping blood in the heart or maintaining the brain. So we start to see some of our body systems slow down and shut down. And that's where we see dysfunction and some of the specific symptoms we'll talk about here in a bit. With the breakdown of those energy stores, first, we go through that glycogen. So when we had energy balance, we were building this in the liver. We start to break that down, use whatever energy we can take from that. Once that's depleted, the body has to look for another place. Usually it would go to food, use that energy, kind of rebuild that glycogen store. But when it doesn't have food, it goes to the next best source, which are the fat stores and the muscle in our body. So it starts to break that down to try to get any energy that it can. Once that starts to deplete, then the body has to go to the next best thing, and that's its own organs and tissues. So it starts to break down those to get any energy that it can possibly get. When we start to break down tissue that's affecting the heart, that's when we start to see effects like low heart rate. And for us clinically, that's when we know that we're at such a severe state of energy imbalance that the body doesn't even have enough energy for the most basic function of pumping blood through the body. And that's when we're talking about hospitalization, acute intervention, where food is the absolute most vital medicine. And that's when we need to go beyond the outpatient setting and into something more directed as an intervention with nutrition. So getting into treatment a little bit, a couple ECHO sessions ago, we talked about the interdisciplinary team, and really that is the gold standard for eating disorder care. When we're talking about specific medical changes, the real treatment is the nutrition piece of that. So nutrition rehabilitation is the way to reverse some of the medical changes that we see as a result of eating disorders. The other really important piece is stopping purging, because that can cause a lot of the medical complications. But between nutritional rehabilitation and discontinuation of purging, these are the mainstays of treating the medical parts that are affected by eating disorder. I do want to say a note about pharmacotherapy. That medications are not an initial or primary treatment for anorexia. There is some evidence for medications for binge eating disorder and bulimia. I'm not going to focus on those for this presentation. I think it's an interesting topic for the future, but especially for anorexia and usually for bulimia, our number one go-to is going to be nutritional rehabilitation and stopping purging. All right, we're going to take a little tour here of some of the body systems. And I'm going to point out what things are specific for purging, and then some of the more important ones that I think any part of the interdisciplinary team can kind of have their antenna up for. So starting with the heart. In the state of starvation, the amount of heart muscle actually decreases, so the mass of the heart decreases. This causes less blood to actually be able to enter the heart, thus less blood being pumped through the body. So some of the symptoms that you can see associated with that are decreased stamina, decreased exercise tolerance, tiredness, fatigue, having some effects of that decreased circulation, so cold, blue, purple hands and feet. This is a picture to kind of demonstrate that change in the cardiac mass. So you see in the top, that's what a typical heart silhouette would look like in this cut of the image. And then the second is somebody with restrictive eating, so you can see the size quite different there. Because the structure of the heart muscle changes, it doesn't support the valves quite as well. So you can even have valve abnormalities into the heart where you're getting blood mixing into different chambers that it's not supposed to be in. And this can cause things like chest pain, some racing heart. You can actually hear a difference in the stethoscope. Another thing that can happen is some fluid buildup around the heart. And I think it's important to note that all of these structural changes that happen with starvation are actually reversible once nutrition is improved and the energy balance is restored. So these are not things that maintain long term. Once things are in a better position in terms of energy, these actually get better. Increased cholesterol levels is something that happens many times in malnourished patients. It's kind of perplexing sometimes to think about, but what happens usually is the good cholesterol or the HDL increases quite a bit, so that increases total cholesterol levels. So that might be something that people see on labs. And then for purging, we'll talk more about electrolyte changes, but those are primarily what we worry about in the context of the heart, because those changes can influence the heart function, can lead to heart failure. You can also get hardened arteries and vessel or vascular disease that's more specific to purging. In terms of function, I already talked about the importance of heart rate, that being a really essential marker for us to know when we're at a critical stage of energy imbalance. It's interesting to think about patients who are malnourished who actually have normal heart rates. If a patient is sick enough where you suspect that they would have a low heart rate, but they have a normal heart rate, just think about why that might be. Many times this could be anxiety, it could be medication effect, and it could be other complications. So it's really important to not take the value at face value and really think about the patient as a whole and what else might be going on. And with low heart rate, people often describe having a racing heart or like a skip beat. You can also get blood pressure changes, so low blood pressure, just that baseline. Many people complain about having blood pressure changes with position changes, so like going from lying down to standing up. Some people can get symptoms like weakness, dizziness. Some people get to the point of fainting. If fainting is what you're dealing with, then that's usually an indication to have more urgent evaluation, at least in the office or in the ER urgent care. Oftentimes, fluid resuscitation is enough to get past the fainting part, but people can experience these position changes for months after refeeding. So it's something that takes a really long time to get better. And some providers will be tempted to kind of evaluate for postural orthostatic tachycardia or POTS syndrome. But in an acutely ill, malnourished patient, usually the cause is the malnutrition and not another underlying disease. So just be careful about that. EKG abnormalities can happen. This is usually related to the underlying electrolyte changes from malnutrition and refeeding. So prolonged QTc syndrome is one to look out for because that can be associated with the risk for life-threatening arrhythmias. And you see like chest pain. Decreased variability in heart rate. So when we go up like 3 stairs or walk across the room or stand up from the couch or whatever it is, our heart rate should vary some. And when our body's functioning, normally it does. In eating disorder patients, the signal from the brain to the heart that tells it to do that might actually be interrupted. So you might not see that variability, and the heart rate can stay really, really steady. The reason this is important is because even outside of eating disorders, not having that variability in the heart rate is associated with heart failure. So just another marker to consider, not something that you ever need to do like 24-hour monitoring for, but if you're monitoring somebody and you're not noticing those changes, just another signal for you to have an idea of their degree of malnutrition. And then with purging, we'll get into this in more detail, but the electrolyte changes can cause EKG and rhythm changes, and those are potentially lethal. And move on to the reproductive system, switching gears a little bit here. So the biggest marker that we're looking for here is secondary amenorrhea, or irregular periods or having periods stop. Again, the way we describe this to patients is not having enough energy to maintain the reproductive system. So essentially that's why the periods stop. But some patients will experience profound weight loss or be considerably low weighted and still get their periods. Or some patients will get their periods back shortly after starting the refeeding process. So it's not always a reliable and reassuring marker, but definitely something you can use in certain cases. Resumption of periods can take some time too. So it can take, on an average, 9 months for patients, sometimes even longer. Usually it comes back at around 90 to 95% of somebody's goal weight. And if it's persisting beyond a year, a patient's been doing well otherwise, not having any other medical complications, you might consider covert behaviors, exercises, and stress, because those can continue to contribute to period stopping, even beyond the initial refeeding period. It's also important to know that patients can still ovulate if they're not having their period. So if a patient wants pregnancy protection and is having sex in a way that could lead to a pregnancy, would still consider birth control options, because the amenorrhea alone does not necessarily prevent pregnancy. We'll talk about the interface between the reproductive system and bones next, but know that there can be some growth delay that's related to having periods stop and not having enough estrogen or testosterone in the body. Decreased libido is another thing that can happen, and it was actually one of the more surprising findings in the Minnesota starvation study. That's kind of one of the symptoms I think about if somebody brings up, just to have on your radar if other aspects of their care are looking towards eating disorder, to kind of consider that as part of it. And there's structural changes too. So the uterus length changes, the lining changes, and the ovary and testicle size can decrease too with malnutrition. Moving along here to the endocrine system. So hypoglycemia is something that we commonly see, and this is because the patients are not taking in very much glucose intake, and they've already used those glycogen stores. So we can see patients with pretty low glucose levels. This is something that is also a good indication to go to the ER if you're finding this. Usually can be taken care of with fluids that have glucose in it, but if not treated, can have negative outcomes. Some of the side effects to look out for are like tremor, dizziness, lightheadedness. There could be changes on thyroid levels too. Some patients will get associated symptoms with this, like cold intolerance, depression, fatigue, constipation, but it's a little hard to tease out with those more non-specific symptoms. And this usually doesn't lead to long-term thyroid illness, so rechecking after 4 weeks of refeeding will usually show normalization in these abnormal labs. Hypothermia can happen as a result of abnormal thermoregulation. And for purging, there is a higher rate of bulimia in diabetic patients, and this isn't a DSM-5 criteria diagnosis, but diabulimia is also common for patients who have diabetes. And insulin withholding can be really dangerous, and these are some of the kids that we think of as the most high risk for negative medical outcomes, because if they go into diabetic ketoacidosis or DKA, that can be potentially legal or have really severe morbidities compared to what we see with some of our other eating disorders. Moving on to the bones. All right, so I alluded to this a bit ago. There can be severe bone loss related to malnutrition. And we think of it in relation to when people's periods stop. So if they've not had a period for more than 6 or 12 months, we start to think about what is the effect that not having estrogen in the body is having on the bones. And when they look at the degree of severity of bone loss in people who don't have periods because they have eating disorders versus people who don't have periods for any other reason, those with eating disorders are actually a lot worse. And multiple factors come into play. So it's not just the low estrogen. There's changes in growth hormone that affect it. There's changes in the cortisol level. And we know that weight-bearing exercise is really good for bone health. But even for those who are really active with exercise that have eating disorders, it's really not very weight-bearing because there's not much weight to put on the bone, so it doesn't really help in this sense. So something interesting, specific for eating disorders here. You can see weakness, swollen joints. At its worst, you would see pathological fractures and pain. Many people are also tempted to treat this with birth control that has estrogen in it. And the studies that have looked specifically at this actually show that birth control pills don't help. That level of estrogen actually doesn't help with bone health. Some institutions will do lower dose estrogen, which does actually show some evidence that it might help with bone health. But many, I know, at least in the adolescent world, many providers still aren't using that. They're focusing on nutritional rehabilitation. Though it may be an option in the future years. And people always ask us about the DEXA. So a DEXA is useful if a patient hasn't had a period for 6 to 12 months, and you are concerned either A, about prior fractures, their potential for future fractures, or kind of as a tool to kind of give you an idea of what medical complications you're dealing with. Regardless, though, the treatment is still going to be nutrition, and seeing a low bone mineral density on a DEXA scan can tell you to optimize calcium and work with the nutritionist to make sure that you're getting calcium-rich foods in and optimize the vitamin D level, but ultimately it's going to come back down to improved nutrition. And you got to be careful about recommending weight-bearing exercises. As soon as the eating disorder hears the word exercise, it's going to tack onto that and run with it. Let me check my time here. All right, moving to the GI system. The delayed stomach emptying, I think, is one of the more common symptoms that we hear about in terms of the GI system. So people have bloating, abdominal discomfort, early satiety, or feeling full. It can even get so bad that people experience nausea or vomiting. And that kind of backs things up in the upper GI system. So you can even have some reflux into the esophagus and cause some heartburn. Again, the best treatment here is nutrition. Some people will trial medications that can move things quicker through the GI system, but these are usually short trials because of the risk of side effects and because of the risk of these side effects in light of what might be going on in other systems. So you really try to stay away from medications, even for the delayed stomach emptying, and focus on nutrition. Constipation is really common. The GI system is essentially going to sleep so that it can send that energy back up to the heart and the brain. So it doesn't give the opportunity for stools to move around in the colon. So we see this commonly. We really recommend optimizing water intake in these cases. So making sure they're getting those 6 to 8 glasses of water. Really avoiding stimulant laxatives can actually make constipation worse. If any medications are needed, we kind of use the go-to of osmotic laxatives like Miralax, something that's going to bring water into the colon but not necessarily stimulate it to move. So if you have to use any medication, Miralax is usually the way to go, but you also have to counsel the patient about needing the water to actually help the Miralax actually work. Can see lab changes with the liver enzymes. Usually the liver function isn't affected. The liver enzymes actually are one of the things that improve after 4 weeks of refeeding, so it's something to check, but not necessarily something that's going to have big clinical implications. And SMA syndrome, mesenteric artery syndrome, is another interesting but rare thing that happens in restrictive eating disorders. But I think we get a lot of questions about that too. So this is when a piece of the intestine kind of gets trapped in between two of the big arteries lower in the abdomen. And that piece of intestine is usually surrounded by a fat pad that protects it from those big arteries. But as we talked about, the fat pads break down, and theoretically, the piece of intestine can get trapped between those two vessels and cause some obstruction and pain. Because of rare, on the more rare side, if somebody's having a lot of abdominal pain and nausea, it's definitely more likely because of the delayed stomach emptying and the general slowing of the GI system as compared to something more rare like a kidneys. I'm not going to say too much about kidneys here. Most of it's related to the electrolytes. You can see a low creatinine, so I wouldn't be surprised by that. This is related to the decreased muscle mass. Dehydration is something we commonly see. And then you see kind of what you would expect for symptoms associated with baptism. And then we have all the electrolyte changes, which we talked about. Lungs is another system that's not too affected. So you can get wasting of the muscles that help with respiration, so can experience some challenges with breathing, shortness of breath, lung capacity. This is not something that we see early on in malnutrition, so this is really more of a late manifestation. And sometimes there can be an air leak into the space around the lungs because the walls of the air sacs becomes weak. Not something that we very commonly see either. That would be associated with like cough and chest pain. Encouraging because the vomit is coming up from the stomach through the esophagus. It can kind of backtrack into the trachea and into the airways, so that can cause aspiration pneumonia. So just something to consider if you are seeing a patient with aspiration pneumonia, trying to figure out why. As far as hematology goes, all the blood lines can be affected. So you can have low white blood cells, low red blood cells, and low platelets. You can see some impaired immune response, fatigue, easy bruising. The changes in the bone marrow usually are not to the point of requiring transfusion. So if that's the case, we got to think outside the box of what else might be happening. And we're usually seeing one or two cell lines. It's pretty rare to see all three at the same time. So if you're seeing all three at the same time, also want to consider other possible causes. And we also expect this to improve after 4 weeks of refeeding. So there's just another lab test that you want to recheck to make sure that things are going in the direction. Okay. For the brain, we had another echo session that talked a lot about the implications and the different parts of the brain and how they interact and contribute to eating disorders. So I'm not going to go into that stuff, but I do want to talk about this risk for leaky encephalopathy. So this is associated with confusion, challenges with eye movement, challenges with walking. What we see more commonly is trouble thinking, understanding, not being able to concentrate in school, poor memory, slow word finding, or slow speech. This is really related to a thiamine or vitamin B1 deficiency. So this is one place where we do supplement. Vitamin B1 is pretty benign, does tolerated really well. So we're often using this for patients who are malnourished to the point of having any kind of cognitive change. And theoretically, it can also progress to this more severe Korsakoff syndrome where you have frank amnesia and that has a poor prognosis, but this is pretty rare also. There are structural changes in the brain also, so the brain actually gets smaller, there's bigger spaces, kind of telling this image, these kind of wider spaces in between the brain matter, and overall smaller than what you would expect. For the skin, There's a bunch of different symptoms you can experience in here. So it's dry skin, hair loss, having that fine hair growth over the body, especially the face, the back, and the lower trunk. You can get some skin color changes, so yellowing or orange color of the skin if somebody is eating a lot of vegetables that have those certain colors to them. And then scarring or calluses on the back of the hand. This is usually for people who purge because as the hand hits the roof of the mouth and the teeth, you can form some calluses there. And then pressure sores is also more related to patients who are either on activity restrictions or are on the very ill side. It does warrant doing exams of the back, over the sacrum, over the spine, to make sure you're not dealing with any pressure sores, because the delayed wound healing can also contribute to prolonged and complicated sores. And the last place on this tour is oral health, and most of this is related to purging. The gastric acid that comes up with vomiting does soften and erode the dental enamel, so you can see sensitivity to hot and cold foods, decalcification, erosions, cavities. You can see gum disease, lip inflammation, cracking at the sides of the lips, and then damage to the roof of the mouth and mouth molars. I wanted to spend some time talking about refeeding syndrome. This is kind of the big worry when we start to refeed somebody, knowing that the treatment for all the stuff we just talked about is refeeding. So the big thing about this is that we see a lot of fluid and electrolyte shifts. It's potentially fatal because of these shifts, and I'll show you why here in a bit. And I want to talk about who's most at risk. So anybody who has had little nutrition and then increasing their nutrition through refeeding is at risk. It doesn't matter their BMI. There are certain risk stratifications that do matter a little bit about BMI, but anybody who is changing their eating in this way is at risk. So just because you see somebody with a normal BMI on a growth curve doesn't mean that you don't have to worry about refeeding syndrome. Those who are at higher risk, though, are those who have been in the first stages of refeeding. So in the first 2 weeks is when you really have to think about it. If they are severely malnourished or low-weighted, the literature cites like a BMI Z-score of -2 or lower, but again, this can happen at any BMI. If they've had rapid weight loss or weight loss of more than 10% of their usual body weight in the past 3 to 6 months, and then if they're refeeding really rapidly. And you have to be careful for people who might go from severe restriction to severe binging. But again, any BMI can be affected. So in these last few minutes, one of my favorite things to go through is what refeeding syndrome actually is and what's happening in the body. So I'm going to go through that. So we're in the stage, breakdown, dysfunction. We're breaking down our tissues, we're breaking down our fat stores, our muscles, anything we can to get energy. And then we move into refeeding, where now our primary energy source are carbohydrates that we're getting from food, and that's turning into glucose. We want to use that glucose in our cells because they have lacked that and need some sort of energy. Once glucose is in the picture, that increases insulin secretion from the pancreas. So the insulin is going to be what brings the glucose into the cell so they can use it. What insulin also does is brings in other nutrients and electrolytes that the cell needs to create energy and to function well. So it's helping bring in the phosphorus, the potassium, the magnesium from the blood into the cell. So great, we have more potassium, phosphorus, and magnesium inside the cell, and it decreases what we have available in the blood. So in this state, the cell is happy, the cell feels like it has enough of what it needs, it has the phosphorus, it has the glucose, it's a little factory making energy, trying to get back to this growth and storing into glycogen and normal functioning stage. And it continues to make energy that decreases what we still had in the blood. continues more and really decreases what the blood levels of the phosphorus, potassium, and magnesium are to potentially a dangerous level. So there's no, virtually none of these substances traveling through the blood to go to other body systems to help the other cells. We're really using what we have more quickly than we're able to replenish it with the food through refeeding. So that's what gets us into trouble with refeeding syndrome. And refeeding syndrome can affect all the body systems. So heart failure and heart rhythm abnormalities are what we're particularly worried about. But we can see fluid shifts, the diaphragm can lose strength, and that can cause some breathing issues. We get muscle breakdown and weakness. We get increased liver enzymes because we're getting actually more fat deposits over the liver. Breakdown of the intestinal mucosa, so we're actually now looking at diarrhea. And then the cells are also using thiamine, so we're also looking at those symptoms of Wernicke encephalopathy if we're not replacing the thiamine. So getting some cognitive abnormalities. There are ways to mitigate this. So starting at a lower calorie level than one may need. So 1,400 and 1,600 is what's recommended. At Seattle Children's, we start at 1,800 to 2,000. So there's some more recent literature that shows that higher calorie levels might be safe. But if you're in an area where you do need to be more conservative, then starting on the lower side is always safer. Avoiding very rapid increases, so we increase from about 200 to 400 calories a day. Again, if you're somewhere where you do have to be more conservative, then you can be more conservative with the increases. And monitoring closely, so we're doing labs daily to make sure we're not seeing drops in phosphorus, correcting any abnormalities, especially before starting refeeding. And if you're ever seeing a phosphorus level that's less than 2, that is critical. So that needs to go to the hospital, needs IV repletion and cardiac monitoring. All right. So in these last 2 minutes, I'm going to give you some pearls, but I'm Crystal, so these are crystals. So one thing I want to say that eating disorders can affect everybody. I'm going to say that so many more times to drill that in. And I want to say something about growth curves. They're great provider tools. So when we have babies, they show us like head growth. When there's concerns about height growth, it's a really easy way to see when people are crossing growth curves. And really, many times providers are using growth curves to identify eating disorders. So they're really valuable in those ways. Not so much for patients and families most of the time. So I think one thing that's really important is to be mindful about what use you're using a growth curve for and what would be the purpose to show that to a family or patient, because we know in the instance of eating disorders, it can be pretty harmful. So just having a purpose and a reason and kind of an idea behind needing to use those that in a patient-facing kind of way. Using neutral language, so trying as hard as possible not to refer to things as junk or unhealthy or anything related to how somebody might look. So applauding or the opposite of that for either growth or weight gain or weight loss. Just trying to keep things really neutral. And that goes to this idea of weight neutrality, just understanding that some people may never love their body. And if we keep hammering into them, like, oh, I want you to love your body, I want you to love your body, that might not be what works for them. And taking a more neutral approach might be the better route. And then just having an appropriate index of suspicion. Not everybody that presents with the symptoms we've talked about today is going to have an eating disorder. But if the combination of symptoms is right, you want to make sure to be able to intervene as soon as possible. And I just have some other reference stuff here. You can look at the things that I look for first for like urgent evaluation, for medical stabilization, and then some other things that a primary care doctor can do.
Fantastic. Thank you so much, Dr. Cuellar. That was so great. And it really reminded me, I loved how you brought in the showing of the different body systems. I've heard recently someone say that eating disorders leave no body system unspared. And you really showed that and highlighted that tonight. So we do have some questions in the chat, and we'll start with those. And if you have a question as well, feel free to use that raise hand function. So one question for you, Dr. Cuellar, when do you recommend an EKG? And when do you, in addition to blood work like a CMP?
So at baseline, I think it is helpful to do both. So it is a good idea to have an idea of what their rhythm looks like at baseline so that if there are issues in terms of symptoms later, you have something to compare to. And same for labs. So it's useful, I think, when I see, okay, this patient has completely normal electrolytes, completely normal kidney and liver function at this point. If something changes down the line, I'll have something to compare to. I repeat EKGs if there's any new symptoms related to trouble breathing, chest pain, dizziness, feeling like they're going to pass out or passing out. They might have those at baseline, so I won't repeat them quite as often. But if it's new, I would definitely repeat it just to make sure you're not looking at a rhythm issue. And same for labs. If it's somebody who's purging, kind of depends on the frequency that they're purging, but you can be, for some people, it can be as frequently as weekly. If they're purging less frequent than that, then you can kind of space it out. If they're not purging, then usually we'll do labs if there's a clinical change. So we're seeing a lot of weight drop or something like that.
Okay, great. Question, are liver enzymes elevated because the body is breaking down the liver for energy? Is that the reason for why liver enzymes increase?
Yeah, so autophagy, the hepatocellular cells are actually breaking down, and that's why you get that liver increase with malnutrition. In the refeeding process, some of it is because of steatosis and fat distribution of the liver, but in malnutrition is a breakdown of the cells.
So a question that some folks also responded to in the chat, but I think is useful to talk about. For those stomach pain issues that you mentioned, can antacids be helpful to help with some of the stomach pain and managing that pain?
Yeah, there's not clear evidence, like in general, for antacids and anorexia that I know of. If it is clearly related to some reflux, and you do suspect that it's related to the acids, and there's not much harm for antacids. As long as you're careful about it being something else for the eating disorder to kind of focus on and use as a crutch. But if it's more so, if you don't have that history of like acid and reflux, then we try to stay away from it generally.
Okay, this is a great question. This could probably be an entire hour's worth of didactics. But so talking about period losses. So if the period is lost, how long does it take to return? And how do you know if you're on track with it? What's the best thing to prevent further reproduction issues later in life affecting a teen?
Mm-hmm. So it can take a while. So if it's a patient who has, so it depends kind of on their development too. So if a patient's been refed, if they are gaining weight, they're not having any other signs of malnutrition, no other medical complications we're dealing with, then we give it really like 9 to 12 months before we start to do additional workup. But at that point, you could do like a workup for secondary amenorrhea. At that point too is when we start to say like, okay, we need to also worry about the bones. So at that point, I would also do a DEXA. But it can take 9 to 12 years, in some cases even 18 months for menses to return. Also important to kind of reassess what the goal weight is and make sure that it is on track with prior weight trends. I think that answered your question, but I think I also answered something.
Great. Some great conversation going on in the chat about it, and especially just issues related to how use of birth control might impact this, as well as that if it comes back after a short period of time, that this can sometimes make patients feel that their weight restored, but be falsely reassurative. So some great conversation going on in the chat. I do want to open it up also to folks, even if you did not put something in the chat. Does anybody have a question for Dr. Cuellar? Feel free to unmute yourself and ask it directly.
Hi, this is Maureen, and I'm a parent of a loved one that went through eating disorder starting in 7th grade. Never did start her period till, gosh, I think she was maybe a sophomore in high school, even though the weight was restored probably within a year. But then, went on as a distance runner, and stress fractures in college kind of ended the career. Does that persist on into adulthood, the potential for the stress fractures? And she's at a healthy weight now and doing great, thanks to Seattle Children's. we spent a month down there, but this was several years ago. I don't think you were part of the team.
Yeah, and bone health is the one of all the things that we've talked about, the one that can be one of the more long-term effects, and it kind of depends on the degree of loss of mineralization that you're starting with, and kind of what the trajectory had been with regaining weight and regaining the function to put on the density to the bone. But that is one of the outcomes that can last for a really long time. And for some patients, we do repeat DEXA scans to see like where we're at with bone mineral density yearly. But I'm not surprised to hear that that is something that she's still dealing with, because that can be one of the more long-term effects.
Yeah, probably in the last, probably the last 3 years hasn't, but had to quit running at the collegiate level as a result. And almost 26 now, and climbs mountains and does run and loves it, and is just in a very different place now, but not having injuries. So that's probably okay to run, but just not at that intensity.
Yeah. So we've got time for about one more question if anyone has one, and after that we'll move over to our case presentation, but we do have time. Looks like Jessica Overgaard has her hand raised. We'd love to hear from you.
Hi, thank you. And I'm sorry if my voice cuts out a little bit. I'm dealing with that local upper respiratory infection that everyone seems to have. But I'm a naturopathic physician, and I encounter I would say more disordered eating than I do actual eating disorders. But I was just wondering, what is the recommended approach for a patient who is quite convinced that they must have some chemical imbalance somewhere? All hormonal testing, Lyme testing. I mean, we've really tested everything. But she has many, if most of these physical symptoms. That was an awesome presentation, by the way. Thank you. So what's your recommendation for, gently bringing to a patient that their signs and symptoms it looks like an eating disorder. It's something I've been thinking about for this particular person for a couple of months now. Thank you.
And what kind of chemical imbalance are they worried about?
They were worried about maybe some like neurotransmitters. We've done a lot of hormone testing, including thyroid. A lot of ANA screenings, and again, infectious diseases like Lyme disease or mononucleosis, so CMV and EBV. So we've done a lot of things that would maybe point to some of those more amorphous, signs and symptoms, but I am kind of leaning towards eating disorder and have been, like I said.
And kind of the context I'm thinking of is when we have patients who come in with missed periods and kind of insist that it's not it's not related to nutrition and their activity level. And we kind of do something similar where we're looking at a bunch of different other hormone levels and a bunch of different other causes and not finding anything else. And I don't know that's what the best approach is, but kind of sitting those patients down and looking at the labs and saying, like, look, we've looked for this, 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 and this. It's none of those things. And then reviewing what we know about energy and how the body works, and trying to get on the same page about exploring eating disorder or disordered eating as a possibility. Sometimes it works if they have some reassurance of some negative testing, but I don't really know the best approach. These are hard situations.
Okay, thank you. Yeah, that's kind of it. Yeah, thanks so much.
All right. So thank you, everybody. Thank you, Dr. Cuellar. It was a wonderful didactic presentation, and I'm excited now to move on to our case presentation.